Well, welcome everyone to tonight's Hand Surgery Essentials. This is the last talk in this particular series. Tonight's talk is going to be Fractures of the Distal Radius, Assessment, Principles of Volar Lock Plating. Speaking tonight, we have a talk by Lauren Grossman, Nick Poulos, myself, Jeff Lawton, Jay Bridgman and Chuck Cassidy will be involved and answering your questions. And then very importantly, and one of the unique features of our lecture series or our webinar series is involvement at a high level of a number of therapists. Tonight we have Paige Kurtz joining us. All of us have revealed our disclosures and they've all been appropriately dealt with. A word on Zoom etiquette. All of your microphones have been muted, and it's not that we don't want to hear from you, but just not to disturb our speakers. So when you enter, your microphones have been muted, your videos have been turned off. We do, however, invite your participation and involvement. We'd like you to use the Q&A. So if you pose a question in Q&A, Jay or Chuck Cassidy will field it. Depending on the question, it might be something they answer and respond to you directly, or it may be something that they indicate they would like to pose that to our speakers tonight, and that way we can all benefit from the question. Again, for those of you who have joined us for our other talks, welcome back. For those of you who just sort of stumbled upon these in the last couple weeks, this actually represents the end of this segment's talks. I do want to let you know about a couple things coming up. One is December 16th. It's a webinar on proximal phalanx fractures. And then we don't have all the specifics, but in January, the Advanced Risk Summit will be a number of Thursday nights, 9 sessions, where we will break up what would have been an in-person summit previously and now to do it virtual. So with that,
I'm going to get started. My name is Nick Poulos. I work at the Mayo Clinic. Several partners, Dr. Reed's on the line tonight as well. And what an honor and privilege it is to talk about distal radius fractures, one of my favorites, and something that we're lucky here that we get to take care of, and the trauma guys don't take them all away from us.
You're muted. We can't hear you. You're muted. Sorry. There you go.
Yep, great. So as I was saying, just another plug for all those courses coming up for AO as things change and we're allowed to meet in person again. Highly recommend, again, the AO courses, both in person and cadaver. So fractures of the distal radius, the goals tonight and objectives. So we want to make sure that at the end of this talk, everyone's able to describe the deforming forces that act on distal radius fractures, identify the physical exam and radiographic signs which indicate or suggest the need for surgical fixation, and then lastly, recall the biomechanic principles that underline the use of volar lock plates, and as we call them, volar buttress plates. So as we go through this talk, I want you to think about this. This is a fairly characteristic extra-articular distal radius fracture, and note the posterior angulation, the deformity, and of course you get that note from the emergency room doctor with FOOSH on it. And just think as we go through what you would do, what would cause you to move towards surgical and non-surgical management, and then what you would want to do in terms of getting them moving, because ultimately you want to wrist with good range of motion that's pain-free. And it's not just about putting a nice volar plate on it. This will be our guide as we walk through, and I'm going to start with the first couple, and then Dr. Grossman will wrap up talking about how the volar plate really works. There's a lot of ways to classify distal radius fractures. There's various eponyms that we've heard, and then there's numerous classification schemes. I think the point of this slide is really just to note that there's a bunch out there and they have advantages and disadvantages to all of them. But one that's useful just to have in the back of your mind is that AOIOTA classification. It's useful for research, and you'll hear people talking about extra-articular distal radius fractures like this one as a 23A2 as opposed to the more complex 23C threes. So just know that this is out there and how to be familiar with this classification scheme. The C3s, this is sort of distal radius 2.0 or 201, that would be distal radius course 201. These have fairly characteristic fracture patterns that they present as well. And you can see this nice picture from Dr. Ree's paper, who's on the line, which I appreciate, and some papers by Dr. Bain's group showing why the articular surface of the distal radius breaks the way that it does. And so whether you use a classification scheme or not, I think this is helpful to sort of know and appreciate the anatomy of the distal radius as we go forward. These aren't just theoretical, you can even see them on the x-rays themselves. You can see those radial column pieces, dorsal wall, the volar rim, and the dorsal ulnar corner with good radiographic views. But again, going back to ours, we're going to spend the majority of tonight talking about extra-articular distal radius fractures and things that are very amenable to volar locked plating. And so you can see that dorsal angulation here. And if you have any question, I think one thing that's really helpful is a traction view. It's a little underappreciated, but when it's reduced or when traction's pulled on it, often the pieces appear a little bit easier. You can see the traction with this space at the STT joint that's getting pulled through it in this image. I think as we talk about anatomy, it's helpful to use a scheme and a sort of classification scheme about how distal radius fractures appear. So this is using the column model to really help you describe the fracture, describe the anatomy, and really describe your reconstruction. So I'm going to use this just to go through some of the anatomy of the distal radius, and we'll start with the osteology. So the distal radius really has multiple articular surfaces. If you think about it, there's the radioscaphoid joint, which has the radial styloid and the scaphoid facet. And then there's also the lunate facet, which articulates obviously the radius and the lunate, but the sigmoid notch at the distal radial ulnar joint. And so while the radial column mostly participates in the scaphoid facet, that intermediate column deals with not only the radial carpal joint at the lunate, but also that sigmoid notch. And so I think this is something that is a little bit underappreciated in distal radius fractures. And I know Dr. Grossman has some good pictures of a nice reduction looking at the DRUJ, but don't forget that this isn't just the distal radial carpal joint, but also the distal radial ulnar joint. And then of course the ulnar head is also important as it participates in the DRUJ too. And we have some cases later, I think, with some ulnar fractures. The attachments are important because that's going to help you appreciate the deforming forces. So on the radial column, you have the long and short radiolunates, or sorry, the long radiolunate and the radioscaphocapitate, as well as the brachioradialis tendon. That intermediate column has that short radiolunate and then the DRUJ ligaments, as well as on the dorsal side, the dorsal radial ulnar ligament and the dorsal radial carpal ligament. And then of course the ulnar column has the TFCC, which is really a combination of multiple ligaments. And so you can imagine when you have an intra-articular distal radius fracture or any distal radius fracture, there's a lot of deforming forces on this. And I think when we talk about bridge plating and external fixation, we talk a lot about ligamentaxis, but think about all the ligaments that are really attaching to the distal radius that you're asking to do work for you. And then when you add on the tendons, it's just a complete mess, right? So all of these are acting in different directions. And that's why we really see dorsally displaced distal radius fractures, volarly displaced fractures. So just remember where you see that fracture, that's not where it was when it broke. It was probably worse than where it broke. And by the time it came to your emergency department, that's where it settled. But these are all the forces that you're combating or using to help you when you use ligamentous taxis for your reduction. This is a quote from Collies that says, the casted wrist will at some remote period again enjoy perfect freedom in all its motion and be completely exempt from pain. And how much I wish that were true. Obviously, most distal radius fracture patients are doing really well at a year, but certainly not true that all of them will enjoy perfect freedom in all of its motions. But certainly there's a big role for non-operative treatment in distal radius fractures, and that should not be ignored in an AO course for sure. This is a okay study looking at sugar tongue splint or radial gutter splints. And this is sort of the workhorse, I think, certainly in our institution, teaching institutions, you get a reduction. And because you can't really assess the distal radial ulnar joint We sort of put them into a sugar tong splint without thinking about it a whole lot. I don't know there's a whole lot of data. In fact, this paper would argue that there's not a whole lot of data of using one over the other. But I'm wondering, I think this is a good time actually to see if Paige could comment maybe about non-operative treatment of distal radius fractures, when she likes to see them for therapy, and when she starts getting them moving.
So that's a great question. It really depends, honestly, how stable you think they are. If they're non-operative, I kind of always expect that there's a little bit of shortening in those non-operative people. So that always worries me a little bit. So, you know, even early on, though, I think the biggest thing that we see sometimes is they're typically older people that you don't want to do surgery on. So if I get them too late, what they do is they come in and say, oh yeah, I've been making a fist, and this is what they think their fist is. And that's where I like to get them early, because otherwise we've got MP issues all over the place, and edema control of those basic things. So sooner definitely rather than later, even if we're not moving the wrist, to start addressing the other kind of side issues.
Yeah, I think that's great. And I think making sure that our splints don't interfere with that wrist range of motion and the ability to make a fist, making sure that MPs can flex down, which is a whole nother talk from several weeks ago. Yeah, thank you very much for that. And then here's something Paige alluded to as well, which is this is on the right. You see this is the graph from LaFontaine, which shows that what the patient looked like on admission, what they look like when you reduce them, and where they went when they went on to union. And so even though we get a nice reduction and a good mold in the emergency department, these fractures tend to redisplace somewhat and settle fairly close to where they started. And so this obviously leads us to the next piece, which is when do we decide that too much settling is happening and that we need to move on for surgery? Some are obvious, right? Open fractures, large open fractures, a neurovascular injury, and acute compartment syndrome, certainly something you want to check for. And I would urge everyone to get 2 points before and after their reduction maneuvers that you get. And then predictive instability, and there's several different criteria out there that people use and algorithms people use to predict future instability, including LaFontaine criteria, talking about age of the patient, dorsal comminution, et cetera, that you should just be familiar with and counsel patients that they may lose, even though their distal radius looks nice, they may lose some of their reduction. So what exactly is unacceptable displacement? These are sort of the numbers that we can all memorize. You can find them on ortho bullets. You can find them in Rockwood and Green. And it needs to be individualized somewhat for your patient. But the general gestalt, of course, is that you want to be assessing the volar tilts, making sure the radial shortening is reasonable, the radial inclination, and looking for articular incongruities. So getting good x-rays is key. Here is how I like to assess radial inclination. I think using the ulna is helpful because the ulna is sort of the straight bone here. And you can assess your ulnar variance, which is minimal here, and your radial inclination on your AP. You can also assess your radial height using that same line. And then on the lateral, getting a good lateral where that pisiform is really lined up between, or sort of over the distal pole of the scaphoid, or between the scaphoid and the triquetrum, that's really helpful for you, or cavity rather. So get a good lateral, assess your volar tilt, and then also the teardrop angle, which can be helpful for intra-articular fractures to make sure that you've really reduced the volar piece, but helps in extra-articular fractures as well. It's sort of another measure of volar tilt in some sense. So I think this is where I'm going to hand it over to Dr. Grossman to talk about the operative treatment strategies when these fail non-operative treatment.
So I'm going to be speaking about the operative treatments and mainly about volar plating. As Dr. Poulos gave great parameters as to what you decide and when you're going to operate or not operate, here are a few different ways that you can fix the distal radius. You can see on the upper right-hand corner, there's an X fix. Upper left, there's a bridge plate. Below it is Pins and plaster, which is not commonly used now, but still is a great way to fix a radius if it's appropriate. On the lower right is fragment specific, and the center is a volar plate, which is what I'm going to be speaking about today. So first I'm going to speak about biomechanics of a volar plate. Basically, it could be fixed angle or variable angle device, and it acts as an internal-external fixator. The screws lock into the plate, and that allows for improved resistance to shear. You don't need any friction between the bone and the plate, and that's not necessary for stability. The plate itself allows for enough rigidity. And so the loading forces are transmitted directly from the bone to the screws onto the plate, then back across the fracture, back through the screws to the bone. And what the screws do is they act as a buttress underneath the subchondral bone to hold everything in place. Here's a nice picture here. You see, we can use a volar plate as a buttress plate, but when you have a dorsally angulated fracture, there's the option of using a dorsal plate, which we're not talking about today, but there's a dorsal buttress to hold it from, say, falling backwards or dorsally angulating. And then you say, well, how do I use a volar plate as a buttress for an extra-articular dorsally angulated distal radius fracture versus a volar Martens, which is a volar shear? And when you put that plate on, you put the screws into the subchondral bone, and those screws with the plate act as a buttress for the dorsal angulation. The advantage to a volar locking plate is that there's direct vision of the volar cortex. You have a strong volar cortex in order to help with your reduction. You've got a great soft tissue envelope as compared to dorsally, where it's really bones and tendons. Volarly, you've got your pronator, and there's a good amount of space. It avoids hardware and tendon irritation, and then those screws are locked and are usually sufficient enough without bone graft for a significant amount of bone loss. And then it also allows for early range of motion. So I know when I do distal radius fracture, within a week, I have my patients at the therapist, they're working on hand range of motion, and a lot of times they're working on wrist range of motion right away. Your disadvantages are there's a possibility of intra-articular hardware, and so we specifically get that 20-degree lateral view, which I'll show in some future films, and that 20-degree lateral view accommodates for the radial styloid in order to get a view directly in the joint to see if there are screws penetrating the joint. There's inadequate fixation. Not every single distal radius it is best treated by a volar plate, although a lot of times it can be. There could be tendon ruptures if you have screws that are long dorsally, and they are sharp screws versus blunted tip screws. They can irritate your tendons, and that's why we use a dorsal tangential view, which shows the dorsal cortex of the radius, because on the lateral Lister's tubercle is in the way. And again, I'll have a picture of that in a little bit. And then also the plate placement, we could see here, these pictures show the watershed line, and that is in the Soon classification, is something to look at where you place your plate. Is it too volar? Is it too distal? And that might cause some tendon irritation. But what's important to note regarding that is you can't just go according to that classification, but you need to have an adequate reduction. So if you have a malreduced distal radius, you slap on a plate, that classification doesn't matter so much at that point. And if you do have to place a plate very distal, a lot of times you should remove the implants depending upon the thickness and the type of implant it is. So most of the time when you perform you plan to do a volar approach to the distal radius or place a volar plate, we use a modified Henry approach, which is going through the FCR sheath. And here there's an incision that you would make directly over the FCR going to the distal wrist crease. If you do need to extend it, you can extend it radially and distally, and you would not go ulnarly because of the palmar cutaneous branch. Here you see the FCR, and the FCR sheath has been opened. It's been then retracted radially, and then you retract the other flexor tendons in the median nerve ulnarly. Here we could see the pronator, and you could see the fracture. There's a rent in the pronator. And here's a distal radius fracture with the pronator elevated off, and it looks nicely reduced here. If you have a difficulty with the reduction with radial height or getting length, you can release the brachioradialis, as is pointed out here, by these forceps. And then you can place a plate on, and that's a volar plate. So I have a few examples here about when to use a plate and the parameters for reduction and what is non-operative. So, or operative, I should say. So if we look here in these x-rays, you look all the way to the right and you say, this isn't so bad, it's neutral, it's not overly displaced, there's some dorsal comminution, but if you look at the x-ray to the left, the straight AP, you could see that the DRUJ is incongruent, as Dr. Poulos was speaking about earlier, that sigmoid notch area. So this was treated with an ORAF of the distal radius with a volar plate getting that coronal alignment. And again, you could see here that now we have a congruent DRUJ. Here's another example of a volar shear fracture of a distal radius.
So Lauren, can you go back to that slide for a sec?
I'm not going backwards. Sorry, give me a second, please.
All right, excellent. So when you do this, at what point do you normally send your patients to therapy post-op, and what kinds of things are you looking for from the therapist? And then if I can get Paige to jump in and talk a little bit about therapy.
So a fracture like this, usually I tend to get my patients into a volar cock-up wrist splints. I usually tend to get them custom made just to fit for swelling. And I do that before week 1. And then by week 1, 2, I'm having the patient in therapy, working on range of motion of the fingers, and knowing that this was a stable reduction and I was okay with this fracture, get the patient working on wrist range of motion as soon as the patient tolerates it.
You said one of the key words to me is said you're certain that it's a stable fixation. I think that's the biggest thing to me, is if I hear from the surgeon that they're comfortable with their surgery, that they feel it is a solid fixation, then kind of my rule of thumb is move everything as much as I can without wrecking your surgery, because we're going to be gaining the best possible outcome. But at the same time, I spend a lot of time educating my patients so we're not looking for the exact same movement you had before. More and more I become convinced, dart throwing motion, circumduction, all those kinds of things, but also that the wrist is really more about stability than mobility. And pretty much my driving force on almost everything in hand wrist therapy is stability is more important, generally speaking, than mobility. Not as many people do push-ups as lifting something with a solid wrist. So keeping those things in mind is a big piece of the education as we move into therapy as well.
Excellent, thanks.
So here is another patient. Here's a volar shear fracture of the distal radius. You can see that the patient on the left side is shortened, is a little bit deviated, and all the way to the right, the lateral, you can see that the carpus is in front of the radius. So this is completely sheared off volarly, and this is an operative indication. So this patient, again, was also taken in the operating room for an ORAF of the distal radius. We could see her on the upper left-hand corner. The height has been accomplished. We have coronal alignment. The radial inclination is there as well. And the central view on the top is just a little bit of an angled view to really get to see into the joint on the AP. We have a radial styloid view, which I always tend to get. And if we look here on the lower left-hand side, there's that lateral that you could see that now the carpus is directly over the radius. If you look at the center picture on the bottom, there's that 20-degree lateral view that you could see that those screws are not penetrating the joint, except that one screw is going into that radial styloid there, but that's a 20-degree view. And on the bottom right-hand corner is that dorsal tangential view. I was speaking again, and you could see that almost triangular shape of the radius and the, you know, Lister tubercle, and here's the outline of the dorsal cortex, seeing that these screws are not penetrating, and that's very important for dorsal tendon disruption. And here's another example of a distal radius fracture, and that's an old scaphoid fracture that a patient ended up coming to me 5 weeks after he broke it. Decided to remove his splint, came with some carpal tunnel symptoms, but clearly this is an operative fracture. As you see on the AP, there's loss of the coronal alignment. It's just completely off, and you might say if in an older patient, you might accept that lateral, but really, you know, you can see here there's loss of bone, which is also can be a challenge. But knowing with these volar plates, they tend to be strong enough that you don't necessarily have to put some bone graft in. And so here's another picture. Again, you could see that you restore the height, the inclination, the tilt, the coronal alignments at the DRUJ. And if you look here on both the central AP and the lateral, there's significant amount of bone loss in both places, but it's stable with the fixation.
Lauren, I have a question for you. If you'll go back to the first injury films for this case, and all of your cases have been great ones, but one of the themes, if you look in the film on the far left, that step up at the DRUJ, and you pointed that out in the earlier case, do you have any tips or tricks on achieving that part of the reduction? Because that's not always well described in other things. Like, what do you do to address that?
So that could be a challenge. So in this case, since it was 5 weeks out, in order to help maintain to get the reduction, I released the brachioradialis, I pronated the radius, and I opened up the dorsal periosteum in order to be able to really make that mobile. And then I was able to achieve reduction. I believe I used a K-wire once I got it reduced. Sometimes I'll use a clamp to hook onto the radial styloid and onto the shaft just to shift it coronally. And then there is one plating system I use that has this special, wonderful tool that I find makes things a lot easier. So when I see that I have something like this, I tend to choose that implant.
Yeah. I was one of the things that I find when you're trying to reduce there's that step up that you can see, you're trying to reduce the epiphysis ulnarly, but what's really in your way is the ulnar head, which is immobile. And so an indirect way to address that step off is to get either like a reverse retractor around the shaft or even like a clamp around the shaft and try to translate the shaft radially. It's almost like you're indirectly, you can't get the distal radius ulnar enough, well, you can get some improvement in another way by getting the shaft a little bit more radially. I don't know if Jeff, if you've had any thoughts on that.
Yeah, I mean, I think those are good tips. And what Lauren said, like a lobster claw or something, that's my go-to move. But at 4 or 5 weeks out, I would worry that would just sort of mush into the metaphyseal part of the distal radius. So with traction, the other thing you can do is use a Galpy between the distal shaft of the radius and the ulna, and use it to sort of push it out. You know, you're trying to translate the radial shaft radially while applying some longitudinal traction.
Sure.
I'm curious what this mystical instrument is, Lauren. What is the nature of this instrument without revealing corporate secrets? What does it do?
It's like a compression distraction device. So it allows you to hook onto one end of a plate and the other end of a plate and kind of twist it and turn it and allow you to achieve coronal alignment, allows you to gain some height with it as well once you've put the implant in.
Interesting.
That's known as the Muller tension device.
The what?
Muller tension device. It allows you to compress the plate across the fracture site, and if you swivel but you need to put a screw proximal to the plate through one of the holes in the device, and the other end of the device will hook into the last hole of the plate, and that allows you to compress the fracture. And if you allow it to hook in after the last end of the plate, it allows you to push away the fracture. So it's called the designed by Maurice Muller.
It helps a lot. It makes life easier. But surprisingly, in this man, his bone did not smush completely when I used the lobster claw, and once I did all those releases, it really was quite mobile, and it worked out very well.
Yeah, I mean, I think that tip of pronating the radius and releasing, making sure you've released the periosteum, whatever healing there's been dorsally, allows that mobilization. So Paige, I'm just interested to hear your thoughts. So, you know, this guy for 5 or 6 weeks has been walking around with his radius functionally short, and then Lauren sort of gets him back out to length. What do you see when you're trying to work with his fingers and eventually his wrist? Are your challenges with something like this as opposed to a relatively non-displaced fracture?
You want a list? Obviously, it is the skeletal shortening, then re-lengthening is going to cause all kinds of kind of trauma to the tissues at a certain level, the muscles, the tendons overlying. There's a whole lot of things going on, obviously ligaments and so on. Have probably effectively shortened at some point in time, and then trying to get things back out to length, which is wonderful that you all are doing that. But then we throw in some edema. And those are definitely the people I start talking to about, you know, realistic expectations and where we're going with this kind of thing. And not necessarily perhaps, you know, even though if you've done a great plate in there and everything else, maybe not looking for completely normal movement again, as much as getting functional movement. And, you know, I can quote all the articles to the patients that they need to hear. You know, we really know you don't need to have X number of degrees of movement, and working on those kinds of things, but more, you know, functional goals, find out what they need to do in their life and work for those.
So basically the take-home message of everything that we've gone through so far is to classify the key components to the distal radius fracture, understand the important parameters for the reductions, understand non-operative and operative management, and know when it's appropriate to operate. Understand how a locking plate works, or volar locking plate works, and when you should use it, and then the advantages and disadvantages to the volar locking plate. And now I'm gonna.
All right, so now as we hand over, so again, any questions? Oh, so there's an interesting question. Please confirm distal radius external fixation's death. In what cases do you really use it nowadays? So that's actually a great question, Rodrigo. So so I don't know if I would confirm its death. Have I used one recently? No, I have not. What do I tend to use instead? Remember all of these volar lock plates that we're talking about, even fragment-specific plates, rely on being able to get relatively rigid, stable internal fixation. So if you don't have that, if you have a very comminuted fracture, very high energy fracture, older patient, osteopenic bone, and you're not certain of your ability to get rigid internal fixation, then you think about doing something else, spanning the wrist. And spanning the wrist in this day and age for a lot of us, external fixator has been supplanted by the internal fixator or the bridge plate. I probably haven't used an external fixator in 8 or 10 years, and have used the bridge plate in its stead. Jay?
Yeah, I would say that I mostly use the bridge plate, but remember that in some older patients, they may not be healthy enough for a long surgery. And I've placed external fixers even under local only, maybe just a little bit of sedation. So some of my older patients that won't tolerate a long general anesthetic, you're not looking for, I would say that the older patient, the octogenarian, for example, they can tolerate a lot of deformity. And I've had some cases in which the displacement is so bad, I'm worried about them getting a non-union because the the segments are not even touching each other, but doing a very rapid placement of an external fixer, maybe 1 or 2 K-wires, they can tolerate that. They don't need a lot of general anesthesia, no general anesthesia. You can do it under sedation, or I've done them under local only. You just need to anesthetize the skin and the periosteum, and you can place an external fixator safely.
Yeah, if I could just add to that, I think those are really good points. This Peter. I think that the benefit of the bridge plate is just so that you don't have pins sticking out everywhere. So I agree with the faculty that that's what I use if I can. But the times that I would use it, Rodrigo, is the obvious contamination where you don't want to put a bridge plate in, or if you're really just temporizing before you do your final fixation. Sorry, that's this guy. And then also, if a patient has an altered anatomy in the distal radius, so let's say they had a previous fracture, and there's a fracture malunion that you're just trying to not worry about, like a radial shaft or a metaphyseal fracture malunion, that bridge plate, it's going to suck up the carpus to that distal radius. And if there's any abnormal anatomy, then it really won't align your carpus to your distal radius. So if there's any abnormality there, then I'll use a bridge plate. I'm sorry, an X-fix. Almost reluctantly, because I really like the bridge plate, but there definitely is a role for it. But I agree, it's been really replaced by the bridge plate.
All right, well, thanks. So we're going to go into some cases. Kevin Malone, are you on the call?
I am here, Jeff.
All right, excellent. So 33-year-old right-hand dominant male airline pilot was tracking his Ducati at Mid-Ohio sports car course, and at almost 100 miles an hour, actually had an isolated injury to his right wrist when he dumped his bike.
Lucky guy.
And it's not advancing.
I think it's on Lauren's screen, so maybe she has to advance.
It says I can control it, but all right. So so these are his X-rays, and what do you think? So obviously very active guy, high demand guy.
Yeah, so, very comminuted fracture through the metaphysis of the distal radius with significant dorsal angulation, assuming there's no history of prior trauma, and this deformity is all from this injury. Doesn't look like there's significant articular involvement, but I wouldn't be surprised if there's some non-displaced fracture line coming up into the lunate facet there on the PA image. The ulnar styloid fragment looks like it's flipped 180 degrees. And so that's a little concerning, just indication of the degree of trauma that went in to produce this fracture. A traction film or a post-reduction film would be very beneficial, just to sort of gauge what we're looking at.
So the resident that calls you about this says, well, it's going to need surgery, so I just put him in a splint. What do you think?
So I think there's definite role to reduce these fractures. Yes, the resident is likely right that this is going to require surgery, but leaving it dorsally translated, dorsally angulated like that is putting a lot of additional tension on the volar soft tissues, particularly the median nerve. And acute carpal tunnel syndrome would be something that I would be worried about. So I would definitely like to get this reduced, just for better imaging, better assessment of what the injury is, but also for pain relief purposes. And then you have less of an urgency to take care of this problem.
Yep, agree with all that. And as Lauren and Nick taught us, that this is something that would benefit from surgery. I did want to bring up, if it's going to let me advance, so as you mentioned, the ulnar styloid is flipped 180 degrees, and there may or may not be importance to this, and I would like to query our panelists here, because there's a significant difference of opinion. But remember that the TFCC, or the deep fibers, the ligamentum subcruatum, the dorsal and volar radial ulnar limbi are attached to that. So in my mind, if I have this fracture after I address the distal radius fracture, so everything that Lauren and Nick taught us to do, again, we came out with a paper about 20 years ago that said a big significantly displaced styloid is important. Subsequent to that, 10 years ago, David Ring said it doesn't matter. It doesn't impact instability. But again, even despite this, after I do my reduction, no matter what plate screw system you choose to use, there's a number on the market that work very well. You know, train yourself to evaluate the DRUJ, and if there's instability, especially associated with a large displaced ulnar styloid fracture, I will tend to put a tension band on it. It sounds like, Kevin, that was your idea as well.
Yeah, I think, you know, obviously the radius needs to be fixed. And so, you know, fix the radius with whatever plate you want to choose. And then, you know, for me and my practice and my teaching, it's, you know, assess the radial ulnar stability. We know that, you know, with this fracture, there's probably injury to the triangular fibrocartilage complex, but the distal portion of the interosseous membrane may still be intact and impair or impart stability to the distal radial ulnar joint. But testing stability and full supination, full pronation, and neutral rotation. If concerned, compare it to the other side. And if it remains unstable, then I would fix, you know, in a similar fashion to what you've shown here, Jeff.
And then Paige, any thoughts on specifically forearm mobilization? You know, we tend to talk about the wrist and flexion extension, and you mentioned, you know, rehabbing in the dart thrower's motion and circumduction. But any tips or tricks on forearm motion for patients?
So a couple things that I would probably think about. Obviously, just wondering what that DRUJ, exactly what's going on there. And as you mentioned, the TFCC, I think probably 75% or more of my distal radius fractures, people complain of ulnar sided pain. Where, you know, we just know there's injury to the ulnar side if there is to the dorsal radial side. But I'm just kind of wondering, you know, what's going on with all those things. We also realize that at some point there's either an injury or probably repair to the pronator quadratus. As well as you mentioned the brachioradialis. So I have to, you know, think in terms of the anatomy is a lot of whack. So I kind of feel like I'm coming from behind when I'm trying to get full supination, pronation, you know, all the swelling in that area and so on. So there's all things I'm keeping in mind. Hopefully all the other therapists in the world are too. But one of the biggest things is just getting people out of that constantly pronated position too, where they kind of put their hand up close to the body. It's either pronated or slightly toward neutral, and just trying to convince them to get into a little bit more supination because so much more function. We can't cheat supination as much to get to our faces and things as we can pronation by using the shoulder. So lots of little things that I think about, just getting them positionally a little bit more functional as well.
Yeah, so did that, got it moving, worked on his forearm rotation. So you see, lost a little bit of extension, touch of flexion, it's his left wrist. And again, worked on forearm rotation and maybe about 5 degrees off in supination, but did very well and got back to his high level of activities in life.
Hey, Jeff, can I make a comment?
Chuck, welcome.
Thank you. To play devil's advocate, an ulnar styloid fracture is a radiographic manifestation of a injury that we know is present. So if you have a severely displaced distal radius fracture, the triangular fibrocartilage is disrupted, whether it's disrupted as a soft tissue injury or as a styloid fracture, it's torn. So I would say that as surgeons, it's our nature to fix things that we see that are displaced by X-ray. Whereas if you don't see the fracture, you're less inclined to do so. And so I'm sort of on the same page as Dave Ring when it comes to this. We know it's torn, and if there's no styloid fracture, we usually leave it alone, as long as it's not dislocated. If it's lax, there's no evidence that non-operative treatment of the ulnar side of the wrist impacts outcome adversely. So I'm just playing devil's advocate there. It's not so black and white when it comes to that particular aspect of it. I think the distal radius part we all agree on.
Absolutely. Peter, Are you able with your
Oh yeah,
childcare
I'm able.
responsibilities?
Yeah, I'm good.
All right. So this is a 37-year-old right-hand dominant woman who's involved in a polytrauma, and we're taking care of her left wrist, and oh, by the way, she's got a thumb metacarpal fracture.
Yeah, that's a pretty bad injury. It's kind of a different element here because there's so much metaphyseal comminution, and then there's really an element of this, not really quite a radiocarpal dislocation, but there's a significant dissociation of the DRUJ. And so here, and then the metacarpal neck fracture, I think that should definitely be stabilized too in conjunction. So here, is this a closed injury?
It is closed. Yeah.
Okay. So I think here, I think the key is not only to reconstruct the distal radius with, you know, looking at it. I think if I was treating this, I would try to get this the best reduced I can, maybe even get a CT if their patient's clinically stable to get that. I don't know if there's any other imaging.
And this is where I think Nick had it in his talk about getting a traction view, because it's, you know, I mean, these are the films we get in the ER, and we know we're going to do something operative and she's in the OR for something else. So sort of while we're there, or, you know, while they're there, you know, if you can, you know, if they're going for their X-lap or whatever, if you can pull on the wrist and get a quick fluoro image, it can really help, and that's sort of a handy thing to have. It's sort of a poor man's CT if the patient's not stable enough to get a CT.
Exactly, I agree. Yep, if they're in the OR for sure, or you know, I would argue that you're going to still treat this. If the patient is stable for it, then I would still treat this by doing my reconstruction with openings too. So I'd be looking at, or at least part looking and radiographically looking at these different fragments too. So a traction view, Jeff, I agree, would be awesome here. But I think going into it, I would just try to stabilize the carpus and stabilize the carpus to the intact diaphysis. And it really would be either a, you know, long volar plate if the distal fragments are amenable to that, or this would be one that you may even have to do some sort of hybrid X-fix dorsal spanning plate with some selective fixation as well, and then treating the DRUJ problem too.
Yeah, I agree with all that. We sort of had a window of opportunity where she was in the OR, and they said, you know, you can have her for such and such a time, and, you know, sort of before bad things start happening in polytrauma patients, we chose to fix it. So as Peter, you said, you know, we want to fix everything. So we fixed that thumb metacarpal neck fracture, fixed her ulnar neck fracture, and this distal radius fracture, as you see here. And again, we were prepared for, depending on what the distal radius looked like, either a spanning plate, a bridge plate, versus fixing it definitively with a volar plate. And based on what I saw on traction views, I thought it was something that was amenable to plate fixation. So we did that.
Yeah, Jeff, I think that looks great. I think a lot of times when we look at these type of fractures, we focus a lot on that metaphyseal comminution. And when you see those fragments that look like they're not reduced, you know, we have a tendency to want to try to get all those pieces anatomic, but that's the beauty of this volar plate, where, you know, a lot of times I'll just kind of put my finger and cover that metaphyseal comminution. And if the, you know, the radiographic parameters that you look for, the length, the tilt, and the height, if those are all okay, then, you know, that's what this volar plate is for. And that, I think that looks awesome.
So then, Paige, you've given us a lot of guidance on, you know, hand, wrist, forearm therapy. I will tell you, this lady had a different therapy plan, though, in that she was discharged to a long-term ventilator support facility for about 5 months, and came back. And when I met her, she was blonde. So you could see her brown hair. She sort of grew the blonde hair out. They cut it off, and that's how much hair had grown back. And basically, they did nothing. They just had her in a volar splint, and maybe some people moved her wrist and fingers a little bit. But this is the first time I saw her again at like 6 months after. You can sort of see her trach scar, and you know, she obviously was not aware of any of this. But this is sort of the natural history of you know, a pretty significant injury. So you can't pick your patients. I mean, she did phenomenal despite, you know, not having access to good therapy. So it's not a knock on therapy. It's just sort of I thought it was an interesting case.
Yeah, she makes us look kind of bad.
But even some of the ones that you know, get tons and tons of therapy don't do that well. So
That's true.
Who knows?
Hey, Jeffrey.
Chai.
You know, many years ago, we had looked at these patients who seem to do like you showed, and then you have those patients who have a beautiful fixation for a 2-part fracture, and they're extremely nervous, squeamish, tentative, whatever you want to call it, and they will not move either their hand or the wrist. So we did a randomized prospective trial comparing early motion to immobilizing for 6 weeks. And interestingly, what we found was at the end of 6 months, it really doesn't make a difference. So I think we have to be a little cautious about emphasizing crazy early motion. You know, you can highlight it to the patient, but a more recent paper also pointed out the same exact thing, that patients ultimately for appropriate fracture will do remarkably well, despite letting them sit for some time.
Yeah, absolutely. And that's helpful for some of our patients that unfortunately can't get therapy, or, you know, depending on where they live or what they have access to. So thanks, Chai.
It comes back to the mobility versus stability thing. I think I can, you know, if you get them stable, and a lot of things take care of themselves, and then you can start moving too. So sometimes that delay works.
Right, and it's precisely those people who are squeamish where we actually need your help more than anyone else, because you literally get to sit and hold their hand.
Hi, can I make a comment? Paige, we know that the motion with the wrist is you know, will come along, but how about the digits? You know, like I almost think sometimes I see people back, they've had a wrist fracture and it's more a digit therapy emergency versus a wrist therapy emergency. You know, that if we can't get them early therapy for their digits, even though they never had a digit injury, they tend to get a lot of digit stiffness. Can you comment on the difference between wrist stiffness after a wrist fracture and digit stiffness after wrist fracture?
I think there's usually, most often for me, I think they're a function of the edema in the hand that just slows things down. It bogs everything down. I'm a big proponent of like really moving the interossei, doing the ABA deduction things. I kind of think that's kind of pumping down the swelling. I teach them it's like bellows of sorts. I think a lot of people don't just work at the fist. I like to work the long flexors as well as the intrinsics into flexion and extension. And kind of working through that whole routine as well. So yeah, and then just even teaching the weird patterns people try to use their finger extensors to move their wrist. So trying to retrain out of those patterns as well. And I get into functional movement as much as possible too. So it might just be picking up doohickeys repetitively, but that's part of their activity, is picking something up.
Yeah, can I make a comment? We did a large series a long time ago on distal radius fractures, and to Jay's point, the principal determinant of outcome was actually digital motion, digital function, and not wrist motion. And so I worry a lot about digital motion as well. And the other half of it is, you know, there are lots of operations we do now to facilitate early return to function. And so, you know, maybe 6 months is not necessarily the parameter that we should be looking at, you know, earlier return. So for me, I mean, I would want to get back to work as quickly as possible, and maybe therapy could facilitate that. Maybe 6 months later, it doesn't make a difference, but you know, you fix my scaphoid now, I'll be back at work in a week. Or if you get me some therapy, you know, early after my surgery, I might get back to work a lot faster. Whereas 6 months, not to say that 6 months is not a valid parameter, it certainly is, but if you know, this is where you have to individualize the treatment post as well.
But by
Chuck,
that,
why don't you stay on your video and see if you can help us with this one. So this is a 45-year-old woman who fell from a step stool, injuring her right wrist.
Must have been a very high step stool. All right, so the PA looks relatively well aligned. It's interesting, but the lateral tells the story. So it looks like a metadiaphyseal extra-articular fracture with maybe disruption of the distal radial joint. Hard to tell. It's very oblique fracture line, which is a little unusual.
It is, and then it's subtle, but there is this sort of basically non-displaced ulnar head fracture. So the initial surgery isn't sort of the controversial part or the interesting part about her case. Let's see if I can.
Got to get that ring off, Jeff.
Yeah, there we go. So she underwent fixation. It was sort of a longer oblique fracture, and we got her moving and fixed the ulnar head. And then, interestingly enough, at about 3.5 months, she says, my thumb stopped working. So she's doing great. I had discharged her. And oh, by the way, my thumb stopped working, which is something that we usually think of when we're talking about non-displaced distal radius fractures that we treat conservatively. And then, of course, my first thought was, oh, are my screws too long? Did I over-penetrate one of the screws in the dorsal cortex and cause an iatrogenic injury? Was planning on doing a tendon transfer, EIP to EPL. And so looked, and sure enough, didn't find a screw there. And, went back and looked at the x-rays, and of course in the operating room looked under fluoro, and nothing was penetrating. And then I talked to a few people, and if you think about it, this is really interesting in that as far as the distal radius goes, it sort of is a non-displaced fracture, meaning that third dorsal compartment is still adherent and attached to an intact distal radius, at least over that segment. So this is a lady that had an injury that isn't supposed to happen with a displaced distal radius fracture, but it happened with a displaced distal radius fracture. And I just sort of found it interesting. So again, I thought for all the world it was one of my screws, but it wasn't. And so we did a EIP to EPL transfer, as you see here. And she did well, but it was just sort of an interesting, surprising, a new method to fail kind of a thing.
That's great. I think, when patients say my thumb's not working, you have to look at the FPL as well as the EPL. And Lauren mentioned about the placement of the plate, I think earlier in the talk. I would say don't ignore a tip from the jockey. If patients are having pain in their thumb, around 4 to 6 weeks post injury or post-operatively, take that seriously. I've operated on a couple of patients who've had attrition of their EPL. It hasn't ruptured yet. And so you've saved them a tendon transfer if you go in there. If they're really having significant pain, I go in and like you said, that's a non-displaced fracture at listers, and there may be either a hematoma, ischemic, or attritional from a little crack there.
And you've done basically like a de Quervain's type release of the third dorsal compartment?
I just transpose it subcutaneously, like you would when you do a dorsal approach to the wrist.
Like your dorsal
through
approach
the third compartment. Yeah.
And what did you find? Like hematoma?
I've done it 3 times, and each time I've found a crack in Lister's tubercle with abrasion on the tendon, that the tendon's wearing out as it's going around that pulley.
Gotcha.
Hey,
Jay, do you have a question?
There's a question from the audience, and that is, in displaced intra-articular distal radius fracture that presents late, how long would you wait before corrective osteotomy? If functionally well, would you leave it versus late osteoarthritis risk? So it's essentially, what's your perspective, your philosophy on an intra-articular distal radius fracture that is already healed with deformity? How long would you wait before you would attempt a corrective osteotomy? If they're functionally doing well, would you just leave it?
Well, I think if it's intra-articular, you know, depending on where it is and depending on the involvement of the scaphoid facet, lunate facet, if it's something you're worried about early post-traumatic arthritis, and it's something that you think you should do for that reason. I mean, Jesse Jupiter had a series, and patients did better if you did it within 8 weeks versus after 8 weeks, I think was their sort of inflection point. I think the ones that are a little bit more of a judgment are the extra-articular ones where you know you're going to do it, but if they present to you and they've got a stiff hand and a stiff forearm, and sometimes I'll actually have them go through therapy, get their fingers back, get, you know, their forearm back to some extent, because you know you're going to make them take half a step back when you do the osteotomy. So you don't want to just jump in, do the osteotomy with an already stiff hand, stiff wrist, stiff forearm, and have them have to recover from that plus your osteotomy. So it sort of depends on the urgency, I would say. But an intra-articular component, I'd probably be more inclined to address that earlier.
That's what I would say as well. I mean, if they can, obviously we don't know when they're going to be referred, but I tell my partners if they have issues, just refer them as quickly as soon as we can get a workup with a CT scan and then try to get it addressed.
Can I make a comment? I think that's one of the most difficult fractures to take care of, displaced late intra-articular fracture. I think if there are multiple fracture lines and there's one significantly displaced segment, but everything else is relatively well aligned, I will wait and let the other part heal. And then it's a very simple osteotomy through the fracture, the old fracture, to fix it. But if there are multiple widely displaced fracture components, I would do it as soon as I can.
Hey, Jeffrey.
Try.
Going to what Chuck said before about EPL ruptures, I think traditionally we've always been taught that undisplaced fracture, EPL rupture go kind of hand in hand, so to speak. But there was a study from Japan a while ago where they took it upon themselves after approval by IRB to explore the EPL in all displaced comminuted intra-articular fracture of the distal radius. And in 2/3 of the patients, they found some kind of an injury to the EPL in the third compartment. So your point is well taken that we normally think non-displaced means EPL rupture, but with Chuck's point, if they complain of pain even in a displaced fracture, yes, it's very likely that they have an injury to the EPL. I don't know the reference off the top of my head, but I'd be happy to give it to anyone who wants to know.
Okay, well, let's see. I have one more case, and I just wanted to, we can run through it quickly just to improve awareness. So again, we talked about the displaced ulnar styloid fracture, and this is a guy who fell 7 or 8 feet off a ladder with a severely comminuted distal radius fracture. All right, there we go. So anyway, fixed his fracture, but the important point, Lauren, maybe if I can just get you to advance, it's not advancing for me. So one thing that we don't think about often is compartment syndrome. So this guy, because of the significant swelling, had a significant amount of swelling and compartment syndrome. So at the time of his surgery, addressed that. And then obviously the importance of early motion. And you go ahead and advance one more time. And do our fasciotomies at the same time we fix his distal radius fracture. And you can see here at about 2.5 weeks, he's already got nice motion in his hand. So important thing to think about, especially in these higher energy injuries. So if you could advance for us, Lauren. So I'd like to thank everyone. And again, for those of you who have been with us throughout these last 9 or 10 talks, thank you. Please stay tuned. There is a webinar December 16th on phalangeal fractures. And then we're putting together a series. We're taking an in-person course and turning it virtual in January on Thursday evenings. Thanks, Lauren, if you could advance. And then remember, after 24 hours, this webinar will be on the AO YouTube channel.
Jeffrey, can I say a word, please?
Chai, please.
Firstly, thanks to all the faculty and all the AONA staff who made this such a wonderful series. We've had 3 series, the Must Know, the Sage on Stage, and now Hand Essentials, as well as all the hand therapists who pitched in and done such a fantastic job with us. So thank you to all of them. Thank you to all the attendees. Over the next 6 weeks, we will be taking a break. Stay safe. We're in for the second surge from the look of it. And we plan to have many more offerings starting in January. As Jeff alluded to, we'll have the Advanced Risk Summit at some point. But we also plan to have a consultation corner where we would solicit cases from you and we'll be able to discuss them. And the format of that will be outlined to you in emails coming up very soon. And finally, we hope to have an offering for all our therapy friends a little later after a couple months. So thank you for being with us. We really look forward to seeing you again, and have a good evening. Be safe.